आनंद जी।
जी सर, गुड आफ्टरनून।
हाँ, गुड आफ्टरनून। कह रहे हैं कि अमित जी को एक बार याद करा दीजिए।
जी जी जी, ठीक ठीक।
A very good afternoon to everybody. Dr.
गुड
Amit.
आफ्टरनून। गुड आफ्टरनून दरिया जी। डॉक्टर
Good
संजय हेयर।
afternoon. Yes, sir. Yes, sir. Good afternoon, sir.
गुड आफ्टरनून।
I think Kamlesh sir is not today present
नो
here.
नो, Kamlesh sir is not present today.
Okay, okay, okay. I think Dr. Amit joined or not? Still he has to join. Right?
I've asked Mr. Anand to just talk to Amit. He has not joined
Yes,
as yet.
he is connecting. He is connecting.
Yeah.
So I just talked to Mehta sir also. He will join within next few minutes. He just came from the hospital.
Mhm.
Yes, Amit Das sir. Good afternoon.
Good afternoon, Daria Saab. Good afternoon, Sanjay boss.
Good afternoon, Amit. Good afternoon.
My background is very,
We
black, no?
are waiting for Mehta.
Are you in tunnel or what?
Huh?
Are you in some tunnel?
No, I'm not in the tunnel.
हेलो।
अपने पे
हाँ
WhatsApp करके
हेलो।
join कर दो।
हेलो। हाँ, गुड आफ्टरनून डियर डॉक्टर दरिया।
Yes, good afternoon, BK Gupta sir from Bikaner. Yes, sir. So, Sanjay sir, should we
Yeah,
start or what?
definitely. It is. We should start. So
So, if you permit, then either you can introduce my brother Amit Das, or else I can
yes,
introduce
yes.
him.
On behalf of Dr. Kamlesh Tiwari, sir.
Yes, sir.
Uh, just a minute. Yeah. On behalf of Dr. Kamlesh Tiwari, Dean ICP, I welcome Dr. Daria, Dr. BK Gupta, Dr. Amit Das, and other participants in this short certificate course on hematology. I request Dr. Amit to kindly start his class.
Thank you, sir. Am I audible?
Yeah, you are audible.
Can I share my slides?
Yeah, definitely.
Is it visible now?
It is coming up. Yeah, you go into the presentation mode.
Sir, first introduce Amit Bhai.
Yeah, Dr. Amit Kumar Das. Amit, can you
Sir, should I introduce, sir?
Yeah, definitely.
So, on the behalf of Kamlesh Tiwari sir and Dr. Sudhir Mehta sir, I would like to welcome you all in this ICP certificate course on benign hematology. And after the XYZ and the ABC of CBC, we are here in this line third from the Dr. Amit Kumar Das. He is my elder brother, and he is a MD FICP, FRCP, FIACM, all fellowships which are available in India. He is having in his credentials, and he is a governing body member, Mid East Journal. He is a member of editorial board of JAPI. He is a past chairman of API Bihar, scientific committee of BAPICON 2023-22, and the most important thing for us all that he is going to be a joint secretary of organizing APICON 2026. So on behalf of that APICON also, he will welcome all of us here in the Bihar, and presently he is executive committee member of RSSDI. So he is having so many to tell, but due to the lack of time, so I would like to call Dr. Amit Das to continue with his talk on pitfalls in iron management.
Yeah. Thank you, Daria Bhai, for your nice introduction. Thank you, Sanjay Boss. And we are absolutely very happy to have this short certificate course. And we are very obliged to Dr. Kamlesh Tiwari for introducing this short certificate course. And double obligation to Dr. Sudhir Mehta sir for giving us this opportunity to interact with the postgraduates and people at large who are interested in medicine to be participant of this short certificate course conducted by ICP. Now, as the journey of hematology goes, two extraordinary classes were taken by Dr. Sudhir Mehta, who talked on ABC and XYZ of CBC. Let's come on to some topics proper, and there would be a series of classes. I presume 20 classes would be there, Dr. Daria. Am I right? There would be 20
Yes,
classes.
sir. Yes, sir.
There would be 20 classes on hematology, and in the first such specific class today, we'll be talking on the iron deficiency, anemia, and clinical pearls. Well, let me start the talk with the first slide of Dr. Sudhir Mehta, that half of our population suffer from anemia. So 50% is anemic. Of course, there were infectious diseases. Malaria was there, malaria is there. Cases of dengue fever is rising, and sometimes it may go down as the season changes. Yet, on top of thing, the preliminary diagnostic information would be CBC that would give you that anemia is a disease of significance in our population. The whole country is simmering with this disease called anemia, and as you all know, we classify anemia based on the level of hemoglobin, and as the hemoglobin changes with age, the definition of classification also changes according to the age group. So we have a children of 6 to 59, 60 months, which is 5 years. From 6 months to 5 years, the definition of anemia is a mild of hemoglobin of 10 milligram per deciliter, moderate to 7 to 9.9, and no anemia if the hemoglobin is more than 11. For children, it's 11.5 when if the hemoglobin is more than 11.5, we would label this patient not to be anemic. But if it falls to less than 11 or up to 11, 11 to 11.4, mild, and 8 to 10.9, moderate anemia. And less than 8 would be severe. A non-pregnant adult, non-pregnant woman, more than 15 years of age, a hemoglobin of more than 12 is desirable, and then we label this patient of not being anemic. But mild is 11 to 11.9, moderate is 8 to 10.9, and less than 8 is severe. For pregnant women, a hemoglobin of more than 11 is desirable, but the patient becomes anemic when the patient has hemoglobin of less than 11, so 10.9. So 10 to 10.9 is mild, moderate is 7 to 9.9, and severe is less than 7. For men, it is 13, which is desirable, but once it falls to less than 13, that is 12.9, the patient can be well labeled as anemic. So a mild anemia is 11 to 12.9, moderate is 8 to 10.9, and severe is less than 8. So the journey of anemia starts with the classification. When do we say patient to be anemic? So let's have a brief overview of the classification of anemia, and then we start the journey. So based on the size of the RBC, we have MCV as an index, which was well explained by Dr. Mehta, that a MCV of less than 100 femtoliter is macrocytic anemia, where you start thinking of folate deficiency and vitamin B12 deficiency anemia. MCV between 80 to 100 femtoliter, we label this patient to be having a normocytic anemia, and the differentials would be hemolytic anemia and aplastic anemia. And once the patient has a MCV of less than 80 femtoliters, we have our topic of interest today, that is iron deficiency anemia. And of course, one of them is thalassemia. One type is thalassemia. We will not be discussing thalassemia today. We'll be discussing iron deficiency anemia. So once you see the CBC and you find an MCV which is less than 80 femtoliters, iron deficiency anemia comes into the picture. Now, Dr. Sudhir Mehta had repeatedly showed this slide, this classification of MCV based on MCV and the red cell distribution width, and MCV low and RDW less normal, the differential diagnosis would be anemia of chronic disease. We'll be calling this as ACD, and thalassemia heterozygous. And low MCV with a wide RDW, our interest of topic, iron deficiency anemia, comes into picture. MCV normal and RDW normal, which means anemia of chronic disease or a sudden blood loss, acute severe blood loss, can have an MCV normal and RDW normal. So we'll be talking on these parameters as the talk goes. Once the MCV is normal and the RDW is still high, we may possibly be handling with an early iron deficiency anemia or a dimorphic anemia where macrocytic and microcytic RBCs are going to be present. Of course, the differentials would be early megaloblastic anemia as well, sickle cell disease as well, and myelofibrosis. High MCV virtually rules out iron deficiency anemia. So MCV low and MCV normal, you should have a thought process of iron deficiency anemia. So this is the overview of the approach to anemia. But let me just start the topic that almost half of our patients with iron deficiency anemia do not have any symptoms. So they suffer in silence. And as you all know, iron deficiency anemia could be the stepping stone for many ICU admissions. Signs which you could see in iron deficiency anemia and symptoms which the patient can feel. So signs which the patient can see is paleness. Patient will say that the patient, attendants will say that my patient has become pale, or the patient himself will say that I look very pale, I look light. You would have a brittle nail, you will have frequent nail breaks, cracks and ulcers in the mouth or hair loss, which the patient will see, and the patient will complain of fatigability, headaches, shortness of breath, difficulty in concentrating. Especially young females in colleges and schools will come to you, their mothers would come to you with complaint of my child is not studying this day, goes on to sleep. Once the book is opened, she goes to sleep. So difficulty in concentrating, dizziness, cold feet, hands and feet, extreme weakness, lack of sleep, and frequent infections. So these are the symptoms which the patient could complain of. And what you can observe in your clinical examination is paleness, brittle nails, cheilosis, or cracks and ulcers in mouth, and hair loss. So these signs and symptoms usually are non-specific, but a high index of suspicion, a proper clinical examination and laboratory test would make your life easy, and for the patient, you would be a hero as well. You all know that iron is usually stored in different parts of the body, and usually 20 to 25 milligram of iron is circulated all across the body every day, of which 1800 milligram is stored in the RBC. The reticuloendothelial system and the macrophages would store 600 milligram. A bone marrow will store 300 milligram, and this is usually circulated in the blood in the form of a complex with transferrin in the form of ferric form, and it is usually in the circulation only 3 milligram, and some of them goes to the bone marrow, some goes to the liver, some is lost through the GI tract. So this is the whole store of iron. And what happens when you have no absorption, or when you take food containing iron. So daily iron absorption usually is not more than 1 to 2 milligram. For an average adult, the daily absorption does not go beyond 1 milligram. For elderly and for early childhood and pregnant situations, the daily iron absorption can go up to 2 milligram. This is carried to the plasma, and it attaches with the transferrin, which is the carrier of this iron, and this plasma based transferrin circulates across, goes to the bone marrow, to the erythroblasts, and supports the erythropoiesis, gets incorporated into the RBC. When the RBCs die off, when they become old, they senicize, and the heme part and the globin part is broken down in the reticular endothelial system, and the iron part is again recirculated into the blood. So the circulation of iron inside the body goes on continuously on a daily basis, and iron loss through desquamation, endothelial desquamation, is also very less. So iron usually is conserved properly in the body between 1 to 2 milligram, and the rest is stored when you take a large amount of iron. Some amount of some amount of the iron which is not used by the body for erythropoiesis is stored in the liver in the form of ferritin. So iron utilization is also done for myoglobin. So this is the way the iron absorption takes place. And from usually the iron absorption takes place largely in the duodenum and the proximal small intestine. And that is a very carefully regulated process, because iron can be toxic to cells as well. Free iron can induce a large amount of reactive oxygen species, which could be deleterious for health. So iron metabolism is carefully regulated. So once you take and the absorption takes place at the duodenum and the proximal small intestine, the iron, at the brush border of the absorbed cell, the ferric iron is converted into the ferrous form. So Fe3 is converted into Fe2 by an enzyme called ferrireductase, and this ferrireductase is then transported through transporters, which is called the DMT1, the divalent metal transporter 1, also known as natural resistance macrophage associated protein type 2, NRAMP2. Once inside the the gut in the ferrous form. This again, iron may be stored as ferritin or transported through the cell to be released at the basolateral surface to plasma transferrin through the membrane embedded iron exporter, the ferroportin. So ferroportin again is a transporter, iron transporter, which pushes the ferric form into the plasma, and inside the plasma the hephaestin peroxidase again converts this ferrous form to ferric form. So ferric form is converted into ferrous form, and it's reconverted into ferric form by another enzyme which is called hephaestin. Now there is a molecule called hepcidin, which is a regulatory protein, and this hepcidin is released from the liver, and it controls the conversion of Fe3 to Fe2 by the hephaestin. So if the hepcidin level is high, the iron absorption would not take place. So iron absorption basically is a carefully regulated process, and if you are taking large amount of iron, it's not going to help you. So this is how this transferrin goes into the erythroid marrow, becomes RBC, and then if it dies, goes into the reticuloendothelial system. So let's come on to the causes of iron deficiency anemia. So you can have an increased demand for the iron, you can have increased iron loss, or there would be less amount of iron intake, or the amount that is taken is poorly absorbed. So what are the causes of increased demand for iron? So rapid growth in infancy or adolescence, which is physiological increased demand. Pregnancy again is another physiological increased demand of iron. And of course, erythropoietin therapy, which is a stimulator of RBC production. When causes of increased iron loss would be chronic blood loss, menstruation, acute blood loss because of any injury or trauma, blood donation. When you frequently donate blood, you may have increased iron loss. Phlebotomy as a treatment for polycythemia vera could be another cause of increased iron loss. So these are some of the causes of increased iron loss. Now there are certain situations where iron intake would be less, like inadequate diet or malabsorption from disease, which is a malabsorptive state. So poor absorption of iron, such as screw or Crohn's disease, or patient might have some kind of surgery like a gastrectomy for bariatric surgery, or any other surgery for some kind of obstruction or malignancies. So because of surgery, iron would not be absorbed because the proximal part of the small intestine and would not be there. So iron absorption could be disturbed, and iron metabolism, and hence iron deficiency could occur. Acute or chronic inflammation can itself cause decreased absorption, and hence patient can have iron deficiency anemia. So increased demand, increased iron loss, or decreased iron intake or decreased absorption are the major causes of iron deficiency anemia in our part. Now, iron deficiency does not occur simultaneously, but there are stages of iron deficiency where the person initially has a normal iron status, no anemia, and hence the first step is the patient starts having negative iron balance. The iron in the body stores goes down, and the indices, the RBC indices would not be disturbed much, but this patient could have negative iron balance, though the hemoglobin would still be normal. Then the stage of iron deficiency, erythropoiesis comes, and finally the stage of iron deficiency comes. And here you see the classical microcytic hypochromic anemia. So let's see what are the index of negative iron balance. So in the negative iron balance, the marrow iron stores have decreased or are just optimal. Serum ferritin is going down, the iron stores are going down, but it's still less than 20. The total iron binding capacity is high because the demand of the RBC is increasing. The serum iron still remains normal, the saturation still remains normal, the marrow sideroblasts are not detectable, the RBC protofibrins are not detectable, and RBC morphology remains normal. So in the stage of negative iron balance, only the serum ferritin will decrease and TIBC will slightly increase. The next step is iron deficiency erythropoiesis, that is iron deficient erythropoiesis, where the marrow iron stores have depleted completely. So you will not be seeing any marrow iron stores, zero. Serum ferritin will go to the lowest bottom, less than 15 microgram per liter. Total iron binding capacity will start increasing to the tune of more than 380 microgram per deciliter. Serum iron now will show a decrease. So it will decrease less than 50 microgram per deciliter. Percentage saturation would go decrease. The myelocytoblast would be less than 10 because the iron stores have gone down, and RBC protoporphyrin is increasing. Now the final culmination is iron deficiency anemia, where the marrow iron stores are zero. Serum ferritin is going down to less than 15 microgram per liter. TIBC is going increasing to more than 400 microgram per deciliter. Serum iron is decreased to less than 30. Percentage saturation is going down to less than 10. Myelocytoblast is less than 10, and RBC protoporphyrin is more than 200. And on the RBC morphology, then you see the microcytic hypochromic anemia. So depending upon what stages are you examining this patient, you may have different set of presentations in your laboratory. So you need to be aware that iron deficiency anemia classically presents before only after 2 stages of negative iron balance and iron deficiency erythropoiesis have crossed. So these are the stages of iron deficiency anemia, and then based on this, you can also, these are some of the same tests which I just enumerated. So from iron deficiency anemia without anemia to iron deficiency with mild anemia, with iron deficiency with severe anemia. So these are the stages of iron deficiency anemia which the patient slowly and progressively develops if interventions are not taken. Now, if you see the labs, the clinical signs and symptoms, as I told you, are not sufficient. So they are non-specific, you may miss. And once your clinical suspicion is there, you cannot very well rely on the clinical acumen for treatment of iron deficiency anemia. You need to have tests. The usual tests I already enumerated, but the following blood tests are required or absolutely required, which is CBC, which includes hemoglobin and serum ferritin. So a protein, hemoglobin, as I told you, is a protein in the RBCs that carries oxygen, and it is well documented, well read. And CBC, you had extensive class, and I already told you the different types of presentation based on the RBC indices, which you can very well diagnose. And serum ferritin is the iron store, and based on that, iron deficiency anemia is well diagnosed. So whenever you see a case of iron deficiency anemia, look for the cause, whether it's nutritional, whether it's malabsorption, whether it's the Crohn's disease, whether PPI is causing the iron absorption to be, no, as I told you, pH has to be low to convert the Fe3 to Fe2, ferric to ferrous form. So if you are taking long or large amount of proton pump inhibitors, the pH inside the gastric milieu would be high and iron absorption would be disturbed. Hence, a chronic use of PPI can lead to poor absorption of iron, and hence iron deficiency can occur. If there are gastritis, if there is an acute or occult blood loss, like gastrointestinal cause of occult GI blood loss, or a genitourinary blood loss, or the patient has increased demand as in pregnancy or in early childhood, the patient may have increased demand. So whenever you see iron deficiency anemia, don't be in a haste to treat the cause. There have been multiple occasions where the cause was slightly occult, and on deep investigations, the diagnosis was made like Crohn's disease. So don't be in a haste to treat iron deficiency anemia. Look for the cause before starting on the journey of treatment of iron deficiency anemia. So one differential which always comes in the mind and without which we should not move ahead is anemia of chronic disease. Now, anemia of chronic disease occurs because the state of inflammation releases certain cytokines which causes absorption of iron from the body difficult and increases the red cell turnover. So based on that, patient can have anemia of chronic disease, and the most challenging differential, or the most closest differential, is of iron deficiency anemia, is anemia of chronic disease. So how do you differentiate between iron deficiency anemia and anemia of chronic disease? So usually in iron deficiency anemia, you would infrequently or very rarely find the presence of rare disease by chronic disease, but in anemia of chronic disease, you would definitely find diseases associated with iron deficiency anemia, like a malignancy, like a cross disease, as I already told you, anemia of chronic disease. Average baseline hemoglobin concentration in iron deficiency anemia would usually be more than 9 grams per deciliter. Anemia of chronic disease would present at a lesser amount of hemoglobin, less than 9 grams per deciliter. Serum iron concentration of iron deficiency anemia is usually decreased, but in anemia of chronic disease, the serum iron concentration is significantly decreased. The MCV and the MCH is usually decreased in iron deficiency anemia, but in anemia of chronic disease, the MCV, the mean corpuscular hemoglobin, and the concentration, mean corpuscular volume, would be normal in anemia of chronic disease. So MCV and MCH would be normal in anemia of chronic disease, while in iron deficiency anemia, it would be decreased. Now, the clue would be serum ferritin concentration, and serum ferritin concentration represents the iron stores. In iron deficiency anemia, the serum ferritin is very less. As I told you, the stages of iron deficiency anemia, and as the iron deficiency goes, the iron stores decrease, the marrow iron stores decrease, and hence the serum ferritin level also decreases, and hence there is no ferritin. So serum ferritin will decrease. So iron deficiency anemia has low serum ferritin. Anemia of chronic disease has increased serum ferritin concentration because of the inflammatory cytokine release, the serum ferritin. You must be knowing that ferritin is a acute phase reactant also. So in anemia of chronic disease, you would see a high serum ferritin concentration. As I already told you, the serum hepcidin is a molecule which is released from the kidneys, and it has a regulatory role in the anemia, in the iron absorption. So in serum hepcidin, the hepcidin concentration in iron deficiency anemia would be low because there is no iron to be absorbed, and hence hepcidin is usually decreased, and it's not preventing iron absorption. By being less, it's promoting iron absorption. But in anemia of chronic disease, the serum hepcidin would be high. It's preventing, because of the inflammation, it's preventing the iron from getting absorbed. So serum hepcidin concentration in anemia of chronic disease would be high. Now, if you see the reticulocytes, the younger RBCs, the reticulocyte would be higher in iron deficiency, but in anemia of chronic disease, the reticulocyte count would be less. Serum folic acid, vitamin B12, serum creatinine, and serum erythropoietin levels would be normal in iron deficiency anemia. Serum erythropoietin concentration would be increased, but in anemia of chronic disease, the serum erythropoietin concentration would be decreased. So serum creatinine might be increased in serum in anemia of chronic disease like CKD, but vitamin B12, folic acid, and erythropoietin levels are decreased, and hence you can very well differentiate iron deficiency anemia from anemia of chronic disease. What you need to remember is that the MCV, MCH, and serum ferritin are classical, easy markers to differentiate iron deficiency from anemia of chronic disease. MCH and MC would be decreased in iron deficiency, whereas anemia of chronic disease would be a high MCV and MCH. Serum ferritin concentration would be low in iron deficiency, it would be high in anemia of chronic disease. Erythropoietin level, if you measure erythropoietin level, which would be high in iron deficiency anemia, but EPO level would be low in anemia of chronic disease. So this was all about the differential diagnosis. And I already told you of anemia of chronic disease and iron deficiency anemia. But there would be certain situations where anemia of chronic disease would coexist with iron deficiency anemia. And here you would see a mixed type of anemia. Now, in mixed type anemia, the ferritin level would be decreased or normal, but the serum transferrin transporter would be high. which is and this ratio of soluble receptor of transferrin to log of ferritin would be high in mixed type. So mixed type, you would see both a combination of anemia of chronic disease and iron deficiency anemia. So you should have this mixed type of anemia picture in your mind when you are dealing with IDAs also. Now, let's come on to a diagnostic workup of this hypochromic microcytosis. Whenever you see RBC smear and you see MCV low, and the picture shows microcytic hypochromic anemia, you should have a full medical history and see the MCVs and the MCH. Now, if the MCV and MCH is low, your differentials would be microcytic hypochromic anemia. And if you are seeing the serum ferritin level and the serum ferritin level is high, your diagnosis should be iron, anything other than iron deficiency anemia. A serum ferritin level of less than 12 milligram per nanogram per ml amounts to iron deficiency anemia, and you should start this patient on adequate iron supplementation. Now, if for 3 months, if the adequate iron supplementation is not able to improve the iron indices or the hemoglobin, you should go on for HB electrophoresis and the HPLC, and you should look in for thalassemias. So let's come on to the management of iron deficiency anemia. Now, management of iron deficiency anemia needs to be prioritized based on the population. So you can have different subset of people who would be suffering from iron deficiency anemia: infants, children, adolescents, women of reproductive age, pregnant ladies, postpartum ladies, and the elderly. So all of these subset of people are people who are at priority in the management of iron deficiency anemia. Now, the following groups are recommended daily or intermittent oral iron supplementation to prevent iron deficiency anemia. So this is a WHO response to the increasing trend of iron deficiency anemia, and they say that infant, children, adolescents, pregnant, postpartum women, and women of reproductive age should be recommended daily daily or intermittent oral iron supplementation. So this is the recommendation to prevent iron deficiency anemia. Treatment of iron deficiency anemia could be oral as well as intravenous formulations, and would be coming on to the details of this. So there are various oral and intravenous iron preparations which are currently available. So the options of oral preparations of iron are ferrous fumarate, ferrous ascorbate, ferrous sulfate, iron polymaltose complex, and ferric ammonium citrate. As far as the injectable are present, you have ferric carboxymaltose, ferrous gluconate, iron sucrose, iron isomaltoside, ferrimoxitol, and ferric saccharate. Now, let's compare the oral versus intravenous iron. So, the oral iron absorption and bioavailability is questionable. So, oral iron absorption has multiple confounding factors which can prevent our oral iron absorption, and we'll be coming onto that part in the next few slides. And oral iron absorption is also affected by inflammation. But intravenous iron is not affected by inflammation, so it can be given even in inflammatory state. And there is a consistent and a definite trend of increasing hemoglobin when you give intravenous iron. Now, oral iron is easy, it can be consumed, affordable, and acceptable to most of our patients. But intravenous iron needs expertise. You need to have a proper setup for transfusing IV iron, because there have been incidences of anaphylactic shocks when you give intravenous iron. So you need to hospitalize this patient or for observation, at least for a few hours. Intravenous iron carries the risk of administration site reactions and hypersensitivity reaction. And intravenous iron you need to have a recurrent or repeated dosing. Now, as far as dosing is concerned, oral iron can be taken 1 to 3 times a day depending upon the formulation, whereas the intravenous iron requires single or high dose or multiple small doses of intravenous iron. So this is basically a differentiation between oral iron and intravenous iron. Now, dietary factors, if you talk of oral treatment, diet could be helpful, but there is a certain limit beyond which iron absorption cannot be taken. Then that is 1 to 2 milligram per day, as I already told you, and this is well regulated. And I already explained in the initial part that hepcidin, which is a molecule released from the liver, controls the oral absorption from the gut. So oral absorption cannot go beyond a limit, and iron itself is a toxic molecule, which can cause increase in the production of reactive oxygen species and the free radicals. And hence, dietary factors can also influence iron absorption. So if you're taking calcium, if you are taking large amount of fruits and vegetables which carry phytates and oxalates and polyphenols, like in the tea, alcohol, coffee, so these can decrease the absorption of iron. So simultaneous consumption of black tea and iron containing foods will inhibit absorption of iron by 60 to 70%. So if you're putting your patients on oral iron therapy, ensure that these preparations are not taken, and hence iron is usually recommended to be taken empty stomach. So what are the absorption enhancers? Absorption enhancers are poultry, meat, vitamin C, fish, and meat. So these are potent enhancers of iron absorption. So hence vegetarians are usually at some amount of disadvantage when treating iron deficiency anemia. But mind it, if you apply your proper knowledge and application, this differences can be easily taken care of. So what are the dietary tips for preventing iron deficiency anemia? So increase the enhancers of iron absorption like meat, poultry, fish, and seafoods. Increase vitamin C like amla, lemon, orange, and tomatoes. Fermented soy sauces and germinated pulse, which can enhance the iron absorption. Prevent iron absorption inhibitors like calcium, particularly milk and milk products, high fiber foods, phytates containing foods like cereals and pulses and green leafy vegetables, and tannin containing foods like tea and coffee. So increase the content of enhancers of iron absorption and decrease the intake of iron absorption inhibitors. So this is the dietary tip of preventing iron deficiency. Let's delve into the efficacy and safety profile of oral iron supplementation. Now, ferrous sulfate, which was in vogue for majority of India, it shows that ferrous sulfate can cause serious side effects, and that may result in poor adherence. And the single most side effect of ferrous sulfate is GI intolerance. So 40% of women with iron deficiency anemia experience GI complaints with ferrous sulfate, and women who are at risk of iron deficiency anemia stop taking their iron supplements due to GI side effects to the tune of 1 into 3. 33% of women will stop taking ferrous sulfate because of these GI side effects. Ferrous fumarate clinically is proven to improve hemoglobin level within 3 months of treatment. So ferrous fumarate is a good option, and improvement in hemoglobin levels within 3 months of treatment has been seen, and sustained improvement with hemoglobin level even after stopping the treatment for 3 months has also been seen with ferrous fumarate. Ferrous fumarate is more tolerable than ferrous sulfate, less amount of GI side effects. IV iron. So the questions are, what are the indications of IV iron? Which IV iron? How to give? What not to do if infusion reactions? When not to give iron? What should be the gap between the blood transfusion and IV iron? The gap between IV iron and oral iron. Monitor the phosphorus if on the ferric carboxymaltose, and keep options for blood transfusion. So these are some of the questions of IV iron. Let's delve into some portions. So what are the indications of IV iron? Number one, is patients who are unable to tolerate oral iron. Number two, patients whose needs are relatively acute, so acute need of increase in hemoglobin. Patients who need iron on an ongoing basis, like continuous GI loss or menstruation, heavy bleeding, polymenorrhea, or menorrhagia. And the last one is more important, patients who are on recombinant erythropoietin therapy. Now, erythropoietin, when you give erythropoietin, that induces a large demand of iron, which cannot be met through physiological release of iron from the reticuloendothelial system or through dietary intake. So in patients who are on iron erythropoietin therapy, you need to preload these patients with IV iron so that the patients have sufficient amount of iron stores on which erythropoietin is going to help more. So these are some of the indications of IV iron. And what are the available IV preparations? So the available of IV preparations, I already told you in my few slides ahead. Perumoxitol, sodium ferric gluconate, iron sucrose, low molecular weight iron dextran, ferric derisomaltose, or ferric carboxymaltose. So to what extent what are the contents? The content of IV iron is ferrimoxitol will deliver 510 milligram of iron per infusion. Ferric gluconate will deliver 125 milligram per infusion. Low molecular weight iron dextran will infuse 1500 milligram per infusion. Ferric carboxymaltose will deliver 750 milligram per infusion. Ferric isomaltose will give 1,000 milligram per infusion, and iron in sucrose would give you 200 milligram per infusion. So what is the amount of iron which is needed by an individual is calculated by the formula body weight into 2.3 minus the hemoglobin need, 15 minus the patient hemoglobin, plus 500 or 1,000 for the iron stores. So this is the amount of iron which the patient would need. And depending upon the amount of iron, you can very well use the content IV formula and plan your treatment part. How to give? Now, depending upon the mode of treatment depends upon the treating team. You can give it in a single high dose bolus, or you can give it in small doses. Usually in patients of dialysis or patients of CKD, the way of iron therapy is small doses of IV iron are given weekly basis and for a few weeks so that the hemoglobin level increases. So what are the indications of red cell transfusion? So when do you plan for a red cell transfusion? Transfusion therapy is reserved for individuals who have symptoms of anemia, cardiovascular instability, continued and excessive blood loss from whatever source, and who require immediate intervention. So acute need. Now the management of these patients is less related to iron deficiency than it is to the consequences of severe anemia. So you are not treating iron deficiency on a priority basis. Rather, you are treating to save the patient from the consequences of severe anemia. So our red cell transfusion is required to save the patient from the consequences of severe anemia. Now, the advantage is that transfusion does not only increase the anemia acutely, fastly, but this transfused red blood cells would add as a source of iron for reutilization, assuming they are not lost through continued bleeding. So once you give up RBC transfusion, the RBC is broken down into the iron and the globin portion, which goes into the amino acid pool. The iron is going into the reticuloendothelial system and is available for reutilization. The only caveat is that the patient should not lose that hemoglobin through bleeding. So RBC transfusion is going to help you in that way. And transfusion therapy will definitely stabilize the patient when you're planning for the treatment for this patient. So stabilization of the patient would be helpful if the patient is having severe anemia. So these are some of the indications of red cell transfusion. Few words about erythropoietin. Now, erythropoietin is a hormone which is released from the kidney, but no, we have biological erythropoietin, which is particularly useful in patients having anemia in which erythropoietin levels are decreased. As I already told you, patients of anemia of chronic disease and anemia of inflammation have low erythropoietin level, and in those situations, erythropoietin becomes the drug of choice. Now, the catch point is, before you start treatment with erythropoietin, you must check the iron status and see the serum ferritin level. So if the ferritin level is low, you should not rush in to prescribe erythropoietin, rather increase the serum ferritin level. Because erythropoietin needs large amount of iron, which cannot be taken by oral therapy, as I already told you. Now, in patients with CKD, which is the usual clinical situation in which we face, iron is replaced. The usual dose of erythropoietin is 50 to 150 units per kg, 3 times a week intravenously or subcutaneously. Now, hemoglobin levels increase to 10 to 12 gram per deciliter in 4 to 6 weeks. That is very fast if the iron stores are normal. 90% of patients would respond to erythropoietin. Now, once the target level of hemoglobin of say 11 or 12 is reached, you can decrease the erythropoietin dose. Now, if the erythropoietin still is not able to increase the hemoglobin, or there is a decrease in hemoglobin, even if the patient is taking regular erythropoietin, that signifies that there is some amount of infection or iron depletion. You should start working on the cause of the non-response to erythropoietin. There are newer erythropoietin drugs which are available now, which can prevent a newer erythropoietin which have carbohydrate moiety attached to it, so that you can give it once weekly, like dalbavapoetin. Now, there are orally available EPO mimetics such as roxadustat, which is usually given in 50 milligram per day, twice weekly, that acts to increase the biological half-life of the active HIF, which is the hypoxia-inducible factor, that has demonstrated activity to increase hemoglobin level in patients with CKD and other settings. So these are the newer EPO mimetics which can increase the erythropoietin level, which can increase the RBC and the hemoglobin level. So these are orally available drugs now. Few words about anemia and pregnancy. So in anemia of pregnancy, if the hemoglobin is less than 11, you should see the serum ferritin level. Now, if the serum ferritin level is more than 30 milligram, you start suspecting causes other than isolated iron deficiency anemia. Now, if the patient is having less than 30 milligram per liter of ferritin level, now you have to plan in which trimester the patient is. If the patient is in the first trimester, start the patient on oral iron therapy, and after a month or say 3 to 4 weeks, see if the hemoglobin is increasing. If the hemoglobin is increasing to more than 2 grams per deciliter, you can continue with the oral therapy. Now, if the patient is not responding so well and the hemoglobin rise is less than 2 grams per deciliter, check for the gestational age. And if the gestational age is less than 13, you should start considering IV iron or RBC transfusion. If the patient is having gestation of more than 13 weeks, intravenous iron should be started and ensure that the hemoglobin levels are reached. Now, if the patient is having hemoglobin, this patient is in the second trimester and the hemoglobin is less than 10.5, the same algorithm has to be followed. Or if the patient is having hemoglobin less than 10.5 grams per deciliter, you should start iron intravenous therapy. Patient in the third trimester, irrespective of the level of hemoglobin, if the serum ferritin is less and the patient is having anemia of less than 11, you should put the patient on intravenous iron. So treatment of anemia in pregnancy is very specific based on the trimesters of the pregnancy, because anemia is going to have a major roadblock in the normal continuation of the pregnancy, normal growth of the fetus, and proper output of the pregnancy. Hence, treatment of anemia in pregnancy becomes very important. So this was all about your iron deficiency anemia. The diagnosis of iron deficiency anemia is confirmed by clinical findings, CBC and iron studies. Women should be screened during pregnancy and children screened at 1 year of age. Supplemental iron should be given initially, followed by further workup if the patient is not responsive to therapy. The underlying cause should be treated and oral iron therapy can be initiated to replenish the iron stores. Parenteral therapy may be used in patients who cannot tolerate or absorb oral preparations. And use of IV iron has increased in recent years with the availability of newer preparations. So thank you very much for your patient hearing, and I would love to have questions.
Thank you, Dr. Das, Amit, for your beautiful lecture on iron deficiency anemia. I think it is the commonest cause of anemia across the globe, and you have rightly highlighted how to diagnose and treat the iron deficiency. If there are any questions, please, you can, I think there's a few questions in the chat box, Dr. Amit.
Yes, I'm just saying that.
Yeah.
Can oral iron and IV therapy be given together, sir? Hello. Can we advise Spinac in IDA in view of inhibit iron absorption? Can a marginal deficiency in B12 or folate mask an underlying iron deficiency? How to manage? An idea with anemia, ferritin 11, hemoglobin 16 should we treat?
Amit, I think you can take these questions one by one and answer them.
Sure, sir. Sure, sir. Can we advise Spinac in IDA? I already told you that there are certain iron absorption inhibitors, and Spinac is one of them. So if you're treating iron deficiency anemia, you should avoid taking any drug which can have iron absorption inhibitors. Any food item which can inhibit iron absorption. So Spinac could be a deleterious food item which can prevent the absorption of iron. So in view of this, if you're not treating iron deficiency anemia, then you can have a Spinac for preventing iron deficiency anemia. But while on treatment, while on oral iron therapy, this should be avoided. Right, sir? Sudhir sir, your comment.
Yes, sir. Yeah, there are more questions, I think, in the chat box.
Can a marginal deficiency in B12 or folate mask an underlying iron deficiency? How to manage? A marginal deficiency of B12 or folate would be non-reflective in the CBC picture. You need to go for blood test. An MCV, a significant deficiency could have a mixed type of picture. And depending upon the B12 and the folate deficiency, you can very well treat these patients. Dr. Daria, can you help me with the questions, please?
Dr. Daria?
Yes, sir.
Yeah. There are more questions in the chat box.
I don't think so, sir. He has already given the all answers of the questions which are in the chat box. I think last one is for Pica, how to go ahead.
Yes.
Pica is basically a psychiatric disorder, and it needs to be taken care of by a psychiatrist. People say that no, deworming could help these patients. So deworming should be advised in these patients.
I think another question: iron deficiency anemia without anemia, ferritin 11, hemoglobin 16. Should we treat?
The crux is, if the ferritin level is low and hemoglobin is not low, should we treat? So this is, as I told you, there are stages of iron deficiency anemia, and if there is early deficiency, the serum ferritin still would be on the lower side and the hemoglobin would be normal. So these are the warnings where you need to understand that this patient is going to develop a frank iron deficiency anemia. Start working on the cause of iron deficiency anemia. And if there are causes which could be treatable, you treat the cause for iron deficiency anemia. And if there are non-cause, like food absorption is there, oral therapies should be instituted. Through dietary supplementation could be substituted. So find the cause of iron deficiency anemia in the early part for the treatment.
Yes, you are right, Dr. Amit. And this is the state of iron deficiency state. And the classical example is restless leg syndrome. Patient has normal hemoglobin, ferritin is low, and one of the manifestations is the restless leg syndrome. Other manifestations of iron deficiency without anemia includes increased irritability and excessive hair loss, which is unexplained. So one should always, of course, treat these patients even if they have normal hemoglobin, but ferritin should always be within the deficiency should be corrected. Then there's one more question. Factors other than nutrition causing iron deficiency more common in Indian population. Other than nutrition.
No, other than nutrition, I think the occult GI blood loss becomes a very significant cause of iron deficiency anemia, especially in the elderly population. Now you
Yes.
see, you
in
can
one
see,
of your slide, you have shown the causes other than the nutritional factors which can cause iron deficiency in Indian population.
BK Gupta sir, you want something?
Yeah,
You
excellent presentation, Dr. Kedas, and thanks to Dr. Dr. Sudhir Mehta for very nice start of this course. This is very important in especially in our country, as we have done one study on subjects attending medical outdoor. We found that around 70% of the subjects, they were having anemia, and more than 50% of them, they were having severe anemia. So anemia is important for contributing or factor or causing disease and morbidity and mortality in such cases. So this is very important. And I think that helminthesis and consumption of the PPI by patients, they are becoming more and more important cause of anemia. Hello, can you hear me?
Yes, yes. Oh, yeah. Thanks, Dr.
Mm.
BK, for your nice comments.
And
sir, I
but
think
one
yes,
thing,
sir.
as Dr. Sudhir Mehta has said in earlier slide on CBC, RDW is very important parameter by which we can differentiate iron deficiency anemia with thalassemia.
I think one candidate is asking again and again, that is there we can give IV oral or the IV iron or the oral iron therapy. So I think
yeah, please go ahead.
I think nowadays IV iron therapy is enough. Why we should give the oral therapy along with that?
No, there are
What's your
certain
take on?
situations, Dr. Daria, where patients are started on IV iron and then they are asked to continue with oral therapy. Usually, what we practice and what are the evidences that at least a gap of 5 days has to be there for IV between IV iron and oral therapy. Sudhir Mehta sir would be the right person to answer this question in a more scientific way.
I think between the two, one has to choose. I think considering the side effects of oral iron, and I think now IV iron has become basically the mode of therapy, unless until patient has only mild iron deficiency anemia, where you can give oral. But combining two is not actually, and there is no rationale behind combining the two. The moment once you load the patient with iron, the most commonly two preparations, IV preparations are available in India. I think there's no need to continue with oral iron.
Thank you, sir.
One more question in the chat box, that once if you have to give the blood transfusion and the iron therapy, what gap should be between the blood transfusion and the iron therapy?
there is no such guideline that has to be there between the gap between IV iron and blood transfusion. What we are doing with blood transfusion is we are averting the significant impact of anemia. So while we are preparing for the investigation of anemia, if the patient is very acutely ill, like the patient has had severe blood loss, and then you need to give the patient IV blood transfusion. There is no point in giving IV iron in those situations. No, but if the patient is having very low hemoglobin, like 2 grams, 3 grams, and then the patient comes, you need to save the patient before you start with IV iron. So there is no such recommendation for a gap between IV iron and blood transfusion. Blood transfusion is to avert the consequences of severe anemia. Once that is averted, you can very well manage the patient with IV iron. Sir, Sudhir sir, your take.
Yeah, there's one more question, Dr. Amit. Novel biomarkers for more accurate assessment of iron deficiency, I think.
So there is RBC protoporphyrin level, which is usually taken to assess the iron deficiency anemia, and the other is percentage saturation of transferrin. Sir, I would like to have your opinion on this.
Yeah, the novel biomarkers would be the soluble transferrin receptor assays.
Yes.
Of course, it's a research laboratory, not available in commercial laboratories. It's just a research parameter, and the log of soluble transferrin receptor to ferritin, they are very sensitive markers. But in one of my lectures earlier, I had shown you that red hemoglobin equivalent is compared now as the gold standard for diagnosing iron deficiency as compared to ferritin. Ferritin was the traditional marker of iron deficiency. Now, with the new parameter of retic hemoglobin equivalent, that is RET-E, or what you call CHR on Siemens machine, it is one of the earliest indicator of iron deficiency, and it's very cheap, reproducible. You can have it within a few minutes. And therefore, this is a marker, I think, which is of more clinical use, even at the rural and semi-urban areas.
One more question, sir. Now, Dr. Neha is asking that in Wilson disease, ceruloplasmin level is reduced, so patient always have iron deficiency as ceruloplasmin is needed for activity of hepcidin in Wilson.
Yes, ceruloplasmin is like it acts like hepcidin, and hence ceruloplasmin in Wilson's disease, because the hepcidin is not active, you can have poor absorption of iron, and hence you will see low hemoglobin in Wilson's disease also. So this is one of the cause of anemia in Wilson's disease. Right, this is a right comment.
Sudhir sir, one more question from Sahari that he is asking that can we get rat hemoglobin level in 5-part cell counter blood analyzer?
Yes. All this you have to put in extra software for the reticulocyte parameters. So all the companies like Sysmex, Siemens, and others, they have those software. You just have to add on to the 5-part counter.
I think we have answered.
So there is no question in chat box. So we would like to ask Dr. Sanjay sir.
No, let me first thank Dr. Sudhir Mehta sir for giving me this opportunity to present iron deficiency anemia. I've frequently encountered situation in clinical practice, and thank you all the postgraduates for being on this platform, and Dr. Daria for always standing by my side.
Thank you, Dr. Amit. Thank you, Mehta sir. Thank you, Dr. Daria, and all thanks to our dean, Dr. Kamlesh Tiwari, for conceiving such a nice program to enrich our knowledge of medicine. So many thanks to our dean, our president, and all the faculties for conducting these courses. Thank you.
Thank you, sir. Thank you very much.
Thank you very much.
Thank you, sir. Thank you, Sudhir sir.
Thank you.
Thank you
Thank
very
you.
much, Amit. Thanks
Thank
a lot, Amit, for your excellent talk.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, Mehta sir.
Thank you, Dr. Sanjay ji.
Thank
And thanks to all the attendees who have been joining this program in good numbers.
Can we
Thank
have record of your previous lectures, Dr. Mehta?
I think, Dr. Sanjay, I think we will share these recordings later
Sir,
on.
sir, we are recording the classes. It will be available after the courses are finished.
Okay.
Also, we are bringing out a book on these different
Yes.
courses which are being run by the ICP, including this benign hematology. So, in the next Epicon, these books the lectures would be in the print form and they will be available as books. So, we are doing the recordings, of course, would be available and the print form would be available in the next Epicon.
Okay.
Yes, sir. We are working on that.
Okay. Thank you, Dr. BK.
Okay.
Thank you, sir.
Okay.
Thank you.